Hi everyone, welcome to the 90th session of our MedAI group exchange sessions. So this week we have Keno Bressem from Charité University of Medicine, Berlin, here with us to speak about their work on training and applications of large language models in medicine. So Keno is a board certified radiologist at Berlin, and his clinical expertise encompasses CT, MRI, ultrasound, X-ray, and interventional radiology. He's also really proficient in computer science, and from his experience both at Charité and Harvard Medical School. And he has over 60 publications in the field of digital medicine. And currently he leads the International Comfort Project, which is an EU-funded funded initiative that focuses on the applications of AI in the treatment of urogenital cancers and is committed overall to improving patient care. So thanks so much, Keno, for joining us today. And I guess before we start, do you have any preferences on how you'd like to take questions? Do you prefer them at the end, or is it okay if we interrupt you in the middle?
Both is fine. You can interrupt me in the middle if it's
awesome.
Questions.
Okay, I guess. So let's try to make this as interactive as possible. And without further ado, let me hand it over to Keno.
Yeah, thank you very much for the introduction. Thank you so much for showing interest in our research. And I will introduce 3 papers, all revolving around training and application of large language models in medicine. So first, the question is, why should we use large language models in medicine? So as a radiologist, for example, I produce a lot of text data on a daily basis. Every report I do is written down. And that's not only true for me as a radiologist, it's true for every medical specialty. So if you talk to a patient, you usually write it down. If you perform examination, write it down. And to create all that information, huge amounts on a daily basis. And this basically contains very condensed information about, for example, the examination. So we write down everything that's important, for example, in the CT into the report. We usually leave out stuff that is not important. So it's a nice way to have extracted condensed information in a standardized format. And also lots of information about the patient, about procedures, for example, the patient history. But the problem is it is not structured. So it's mostly free text, very hard to use. And language models could help us make that information usable, maybe prepare it for other machine learning tasks, or prepare it for tasks in the hospital, like coding, that means like extraction procedures to generate money for the hospital, or optimizing workflows. But there are obviously many language models out there, so why train new models for medical texts? The problem is that we have a word distribution shift in medicine. So we have the general language and the medical language, because we doctors like to express ourselves in a way that other people can't understand us. So we use a lot of other words, most Latin words, to express ourselves and to refer to body parts or procedures and so on. The next problem is that there's even more word distribution shifts between medical specialties. So as radiologists, I'm confronted with lots of requests for examinations from different specialties, and they all use their own words. They use a lot of abbreviations. Sometimes they use the same abbreviation meaning different things, so it's kind of hard to understand what's exactly requested. But this makes it sometimes very hard to understand what exactly is the meaning of the text. And if you would use a normal language model, it would probably not perform as well as a model especially designed for medical text. And the last thing is that medical texts are sensitive of nature. So we have sensitive information, patient information, which may not be revealed to outside the hospital. So using powerful language models, which usually are hosted by third parties like OpenAI, is not possible with medical data. We don't want to disclose patient information to those third parties. So we probably would prefer to have our own specific language models inside the hospital, which makes it much easier handling the sensitive data. That was the reason we started with training a BERT model for general medical text. We started with this project last year. So back then, before GPT 3.5 was known, this was still considered a large language model, I guess. Now it's probably not a large language model anymore. And we trained this specifically for German medical texts, as there was no German medical language model existing back then, at least not a big one. So the most work went into collecting the data set of German medical texts. This was, for example, the whole database of the radiology department at Charité. This corresponds to roughly 4 GB of raw texts. A lot of writing to publishers like Springer Nature or Thieme Publishing Group, which is a big medical publisher in Germany, doing web crawls, for example, crawling PubMed abstracts, crawling doctoral theses from a German repository, where actually every medical doctor publishes their thesis from Charité, and also including some wikis like Wikipedia or DocCheck Lexicon, which is basically a German medical Wikipedia. And we trained 2 BERT models on that. So we trained for BERT style. That means just mass language modeling, no next sentence prediction. And we trained on 2 different versions of the data. The first was all the data, and the second was a deduplicated data set, because radiology reports contain a lot of duplicates. So if I have 2 chest X-rays, they're both normal. The chest X-ray reports will probably be the same. So they exactly the same, maybe except for the date. So this is a duplicate, and there is some literature out there which shows that duplication does not help the model to become better. Maybe it even affects performance in a negative way. So we trained models on the full data set and deduplicated data set. And here on the right, you can see some results on different benchmarks. Some we designed ourselves, like a chest CT classification benchmark. This is a multi-label classification benchmark of 20 different findings, which can be found in the chest CT. And you see that our model, the medical BERT, the German medical BERT, performs the best over all benchmarks. Same for the chest X-ray classification task, which also is a multi-label task with, I believe, 10 different labels. And we also had some other tasks. We cooperated with a company who specializes on ICD-10 code classification and coding, like OPS code classification and surgery reports and discharge notes. There were up to 100 labels. And here again, the medical models mostly showed the best performance, except for the German BERT model, which was a tiny bit better in 2 metrics. The model is freely available. So we published everything on Hugging Face. The paper is currently in archive. We are in revision, and you can download and play with it and maybe apply it, because there are several applications we see where those models could be used for. One is the coding assistant. So extract procedures, ICD-10 codes, and medical texts. So this is important for the hospital to generate money. So everything the hospital does, we need to specifically state what was performed, which procedures, and there are coding assistants who will do exactly that, extract those procedures from the text to generate income for the hospital. And doing this with machine learning models could speed up the task significantly and also improve accuracy. And the other is this model produces very useful embeddings. So I played around with that. You can see it on the right side. I extracted 10 different examinations, so 250 reports per examination, and just used the embeddings, very simple, and then plotted those. And you can see they cluster very narrowly all the examinations. It's a good discrimination between the examinations. And what's also interesting is that if they cluster close together, it totally makes sense. So on the right side, you see in red, the CT of the head, and in gray, the MRI of the head. So it makes sense to cluster them together. On the bottom part, you see in purple, the CT of the chest. Below this, CT of the abdomen. And because the chest will always show a bit of the abdomen will always show a bit of the chest, it makes sense that they're very close together. And also interlinked with the CT angiography, which usually covers the chest and the abdomen and the legs. And of course, you also describe the chest or the abdominal organs in angiography if there's any finding. And the closest to the CT of the abdomen is the sonography of the abdomen. So it makes a lot of sense how it's clustered and shows that this model can produce very useful embeddings which you can use for other downstream tasks. The limitation of the model is
one quick question about
yeah.
this. Because I think this clustering is based on the fact that you have a lot of terms common between these reports, right? Because even if you do a TF, IDF embeddings, still I think those clusters will show up because you have a lot of like common terms between those reports. Why you need a transformer-based model to show that this cluster are overlapping?
Sorry, again?
So why you need a transformer-based model, like contextual model, to show that these clusters are overlapping? Even like looking at the common terms, also the cluster would overlap.
Yeah, so this was just for me to look at the embeddings. So we are currently exploring how useful the embeddings will be the model produces, because we would like to know if...
I think it would be more useful to see that if the abnormal reports in CT or abnormal reports in MR from head, they form a same cluster. That would make more sense. That means the model is understanding something semantically meaningful.
You're totally right. This is something, so this analysis here, the paper was finished at the beginning of the year, and this plot was created by me, I think 2 days ago or 3 days ago, because I became more interested into embeddings. And you're right. This was just first to see if there's any information in the embeddings at all. But you are right. There is a lot of specific words in the text and a lot of overlap. So this is not that meaningful. But what we are more interested in now would be, for example, in the top right, you see a prostate MRI cluster. And you see in the cluster, there are subclusters. And I would be very interested in that specific thing. Do the clusters represent a pathology? So do they represent different grades of prostate cancer, which is what we now aim to further explore, because this will obviously be more useful. I suspect it is, because otherwise we wouldn't have that good performance on the classification tasks. But yeah, you're right.
Because I think your overlapping also is interesting, because you imagine like you have a CT head versus MR head, and both shows the abnormalities, and those abnormal clusters are overlapping together. Then it makes more sense, right? Then it means like the model was able to restore the semantic similarity properly.
Exactly. Yeah, definitely.
Okay.
Yeah, there are, of course, limitations of the model. And the first is it is not really conversational. So you can make BERT generate some text, but it's not particularly good at it. So you can't really talk to it like you can talk to GPT. And the model usually requires some amount of fine-tuning, because the few-shot and zero-shot capabilities are not that good, especially not that good as for the large language models like GPT4. So users, if they interact with a model, they need to code. And this can be a limitation. And this was also the reason why we did a second project in training a conversational medical large language model. And I think there are lots of applications for language models in medicine. At first, they help with accessibility. So interacting with natural language with something is extremely powerful in medicine, because medical professionals can use those models to engage with complex data. They can engage with databases, they can streamline medical workflows. For example, you can ask the model to extract data for you. You can ask the model to search databases for you. And this makes a lot of data in hospital more accessible for users without programming skills. And the models can be very versatile in the tasks. So two of the most important for me is that they are excellent in summarizing content. So for example, you have a long medical file of a patient, and the model can extract the most recent history for you. And they're excellent in structuring free-form text, which will be another project we'll introduce later. And they, of course, can also help writing. I mean, lots of things we do as radiologists or as doctors is writing. So they can help you composing discharge letters, extracting main information, writing a draft, so you don't have to spend too much time in writing a letter, or like retrieving information in a very efficient way to make people more efficient and faster in hospital. So these are the two main applications I see. The others is knowledge sources. So there are lots of papers out there training language models on medical documents, and where they serve as a source of knowledge. So they might assist you in diagnose and consultations. So you ask them for information and they can help you, or ask them for diagnosis. I'm a bit skeptical in that, because of stochastic nature and the risk of hallucinations in the models, it's very risky and it's very hard to know if the model gives you the correct answer. Also, to keep in mind, most models which are out there and which are tested are usually tested on benchmarks for medical students. So they are frequently tested on the USMLE, and you don't want to be treated by a medical student. You want to be treated by a board-certified doctor. So we had their medical studies and then 5 to 6 years of residency where they learned even more and have much more knowledge in their specific field. And those benchmarks are usually not in the papers. Then, of course, again, the data privacy issue. So you cannot send data to large companies. So we prefer to have open source models implemented locally on site, so you can send them your sensitive data. And then also educational use for students. That the model, which serves again as a knowledge source, can help students better understand things, maybe quiz students or break down complex tasks for the students. So when training the model, I think the most difficult task was what data to get. It's definitely quality over quantity. So there were some papers now, like the Lima paper, which showed that you need 1,000 high quality prompts and you beat other models, which were trained on much more data. You need to account for diversity in medical specialties. So there is probably lots of data on internal medicine, but you also want to have things about surgery, neurosurgery, neurology, ophthalmology, dermatology. So that's challenging to know that the model has seen all those specialties. Data sources should be reliable and trustworthy, which is again a big challenge. So of course there are some sites where you know, okay, this is very likely trustworthy, like sites from the government. I think Wikipedia is also trustworthy. Academic papers are mostly trustworthy, but here again, they vary in quality. And then you also need to somehow make this into a instruction tuning format. So you make an automated generation and they can be wrong. So they can be wrong information added in there. You have no way of knowing if it's in there, if there are multiple thousand of instructions. So what we did, we collected different data. So like for one is the Anki flashcards. Anki is a flashcard application which medical students here in the US use a lot. So basically the whole curriculum is in that flashcards. The only problem is it is not a really good question answer. It's more the text, the word is missing, and on the back of the side, there's the word. So we use GPT 3.5 to rephrase this in more conversational style question answers. We use Stack Exchange, which usually have very high quality. So 5 substacks, which somehow are loosely connected to medicine. Wikidoc, which is a Wikipedia-like online wiki. And the main thing which differs from Wikipedia is that here medical professionals are writing the articles, and they also have kind of a review system. And then we evaluated our model on the USMLE. So there are step 1, 2, and 3. There are multiple choice questions, really downloadable from the self-assessment. And this very much mirrors the final exam of medical students. So a bit insights on our training, how we did this. We trained on a single DGX server with overall 640 gigabytes of RAM, 3 to 5 epochs a model. We tried different kinds of training. We tried with low-rank adaptation, LoRa. We tried LoRa with quantized models, and we tried full fine-tuning. We explored 7 billion and 13 billion parameter models, all based on Llama version 1. We couldn't go higher because the server didn't. So we had insufficient GPU RAM. And the batch size was 256 for the big model and 512 for smaller models. And training time varied between 7 hours to 50 hours for different models. If you're interested in the logs, you can look them up. They're openly available on my Weights and Bias site. One thing what was very interesting, which we found, is that it seemed like, so this is the training loss, the low-rank adaptation, the models stopped learning after the first epoch. You see the loss decreases very fast, and then it kind of levels out. Maybe there's a very, very slight decrease, but mostly it stayed at the same level of loss. And this is something I also observed in one or two other papers who plotted their training curves. It was completely different for full fine-tuning. Here, the loss decreased first a bit and then kind of stayed level. And with every epoch, it started to overfit a bit more because there was a drastic drop at the beginning of the epoch and then stayed level. So I cut it off here after 3 epochs. The 13 billion ran a bit longer to 5 epochs. Yeah, our evaluation
I have
showed.
A question.
Yeah.
So in the previous slides, when you're generating the data sets, is it just for the QA format? I see that it's more like QA format.
Yeah, this is all QA format.
So the objective is that given this question, generating the answer, right?
Exactly. Yeah.
But the
this is a limitation I will mention a bit later. Maybe.
Okay. So it's the limitation for that you are going to develop a dialogue model, but it's just one QA pair.
Yeah, so 2 limitations are there. Maybe, so one is completely right, yeah. So medical dialogue is not just one question, one answer. Don't go to the doctor and say, I have a stomach ache, and the doctor says, you have gastritis. It's not how it goes, right? The doctor asks 2 questions. Where is it exactly? How does it feel? How is the pain evolving? So it's more of a dialogue style, and this was not in our data. It was just one question, one answer. So this does not really mirror real clinical conversations. The other limitation is that the most information, so the model learns information, knowledge, not really in the instruction tuning phase. This is more of an alignment, but it learns information during the pre-training. And the issue with the dataset Llama was trained on is that there is no large medical database in the pre-training corpus of Llama. So if I remember correctly, in the Llama 1, there was no PubMed dump in the pre-training. And this is an issue because we try to force the medical knowledge into the model with our instruction tuning, but this probably is not the best approach to get medical information into those models. Does it answer your question?
Yes, but one more follow-up question is that you said this is a instruction tuning, but you are actually using the QA to train the model. Do you implies that QA is a instruction?
Yeah, basically, yeah.
Okay.
Okay, for our results, so kind of what you expect. The larger the model, the better the model performs. And sadly, we found that full fine-tuning was superior to parameter-efficient fine-tuning like LoRa. As you can see, the 13 billion full fine-tuned model performed the best and nearly passed in step 3 of the USMLE self-assessment.
Did you witness any catastrophic forgetting? Did you check for that? In the sense that it's if you fine-tune the whole model, does it forget previously learned concepts?
It's kind of hard to say because the Llama 7 billion we evaluated as well, and we didn't check on other benchmarks with the Llama 7 billion. And it's also kind of hard to extract knowledge appropriately from the 7 billion Llama, as it's not very good in following instructions. So you try to prompt it for an answer, and it generates mostly non-usable output. So it's kind of hard to say if there's catastrophic forgetting. And additionally, in the medical task, as I said, there is not really a medical data set in the pre-training. So it's also kind of hard. So the only thing I could say as an answer is we perform better than the Llama 13 billion, Llama 7 billion on those benchmarks. But this probably does not answer really if the model forgets something because of our fine-tuning. Limitation of the models, obviously, is the model is not trustworthy. It may hallucinate, produce wrong or partially incorrect information. This is a tricky one. It's when I prompted it a bit, played around with it a bit, it usually did not produce obviously wrong answers, more subtle wrong answers, like recommending the wrong medication for treatment while getting treatment right. So this model obviously is just to play around with, just for research, and is not a good substitute for a doctor, and it can't really answer medical questions appropriately. And also we had lots of errors in the data. So I looked in many data points. I saw some errors in open data sets, like there were some missing data in open data sets. And we also had errors in the data sets we created, partly because of automatic conversion. So using GPT 3.5, it's really hard to go through all those 30,000 Anki cards to check if they are correctly converted. But I did find some failures where GPT did not understand my instruction how to convert. And also in the Wikidoc, which you also needed to convert into a more QA format, there were also some errors where it didn't perform so well. So the data is not as good as it should be. And this probably also contributes to this not so good performance on USMLE. With better data, the model could have performed better. Okay, I mentioned previously that structured reporting and structuring of free text reports is one of the strengths of the models. And this is particularly interesting for me as a radiologist, because structured reporting is something you would like to implement as a radiologist. So what is it? It's a standardized format for radiology report creation, which improves clarity, consistency, and usability of reports. There are numerous benefits of using structured reporting in radiology. For one, standardizes the radiology report. So encourages radiologists to use a consistent language. It helps in data extraction. So if you want to find every chest X-ray with pneumonia, you can basically just extract this from the structured report. It greatly improves our workflow. It makes you faster, makes communication easier. Colleagues know where to look for information. It also improves your report, because if you follow a checklist for things to look at, you will not forget something. You will not forget to measure. And this can happen if you do a free text report. So you just forget a measurement, or you forget to look at something. Structured reporting really helps to get better in being a radiologist. And this affects improved clinical decision-making, where we make better patient care. Challenges are that, for example, if we would now implement structured reporting at every hospital, we would still have unstructured free text reports from the last years. So retrospective structuring is a problem. And at the moment, it mostly requires manual work and has a high risk of information loss or misinterpretation. It's also work to convince radiologists to use structured reporting, because many are accustomed to free text dictation and might maybe find it challenging to adapt, or that they're not as free to express themselves. And also, it's a problem if different hospitals all implement their own version of structured reports, which again limits interoperability. And here I see a good role of large language models in structuring data. So as said, large language models are exceptionally good at information extraction and structuring. They can kind of understand structure templates and fill them up with information. They, of course, can process large amounts of data overnight, and it's just a matter of computational resources. And very interesting as well is they can add some domain knowledge in there. So for example, let's say the report mentions that there is a cancer which is 4 centimeters. The model cannot only report the measurement, but it might also know which TNM grade that is. So TNM is a grading we use in medicine, and the T grade mostly refers to the tumor size. So if the tumor is a certain size, it would say it's T1, 2, 3, or 4. And if, let's say, above 4 centimeters is T3, the model could mention this as T3 without that being mentioned in the report, making the structured report more complete. So we tried this out with GPT-4 for structured reporting, and this was a bit of prompt engineering to get it right. So this is a 2-step approach with GPT. At first, we presented GPT with an unstructured report and several templates and asked it to choose the right template. So here, for example, it chooses MRI of the head, because it recognized this is an MRI of the head report. Then we provided it with that set template, and again with the unstructured report, and asked it to use this template to structure the free text report, and GPT did so, and created a structured JSON output, which we then could use, for example, to convert into a table. And I made some examples of that. So at the top, you see an ankle MRI. This is a straightforward examination, several things to look at, and it's not too nested. So you can see GPT extracted all information very consistently. So it got indication right technique, and then everything about the areas like inflammatory changes, bone marrow signal, it put into the correct spot. It could also deal with more complex reports. So this is an MR angiography of the chest. And here it's a bit more nested because you want to describe the different vessels and then also the smaller vessels branching from those vessels. So we have a nested format. And again, this was no problem with GPT-4. It managed to fill out everything. And even in more complex cases. So it's very hard to see, but what I want to show is this is a very complex structure template. It's a MRI of the heart. And here you have a lot of measurements which are taken. And GPT managed to extract all the measurements and put them into the right place of the structured report. So these were all made up reports. They are very, very close to normal reports, but obviously we don't want to send any real reports to GPT, so we just made them up. So if you write a lot of reports in daily clinical practice, you can also write some reports which are essentially the same, just with made up information. And then we checked if GPT did a good job in putting information into a structured template, and it did nearly perfectly. But of course, there are again limitations in the approach. So at first, it can only use information with the text, which is obvious. But one of the benefits of structured reporting is that GPT can help you to be better at your job. Obviously not if it's a post-hoc structuring of the report. There is a risk of GPT wrongly enter information to the templates, but as we observed, this is very, very low. And again, this was a proof of concept, but you probably should not send your radiology reports to GPT because you don't want to reveal your patient information. And it can also be costly if you do it over and over again for millions of reports. Thank you very much for your attention. Should you have any questions now or maybe after the talk, please feel free to also contact me via email.
Awesome. Thanks so much, Keno. I guess before we open the floor out for questions, let's give our speaker a round of virtual applause for the talk. And yeah, I believe we already have a question in the chat, but in general, like maybe we can raise our hands and then I'll call you out to like ask your question. But I think first, Ashish had a question.
Yeah, excellent talk. Yeah, I kind of joined a little late. So towards the latter part, which I heard, this GPT, using GPT to structure free text into like a templated report. I was just curious, like, how do you really check the accuracy of this, right? Like if it misses a word here or, misspells something or like, I'm just trying to figure out like how do you evaluate this? Like, seems like a very manual process to go over the entire report.
Yeah, unfortunately, that was it. It was a very manual process, which we did. We're two authors. We went through all the reports twice and checked it manually. There is no automation approach for this, unfortunately.
Thanks.
I see another question in the chat, which was how to sanitize it. Could you please elaborate again what you mean with that? I think I didn't see it while I was giving a talk. I don't know which slide I was on.
Are you referring to Ashish's question on the chat, Keno? Or
No, it was a direct message to me. The rest can't see it. Yeah.
Hi, I also have one question. Did you, in the last project you showed where you evaluated or where you used GPT-4 to create structured reports, did you do this on English or on German radiology reports? And could you was each GPT-4 equally, did it perform equally well regardless of the language?
We did this on English. So we created English reports and evaluated on English. But with the first project, the BERT project, we also created a benchmark of anonymized text, which we will soon publish. So this is something you could send to GPT because it's anonymized. And this was German. And here we did a classification task. So basically we tested GPT-4 also on the X-ray classification and did a good job there as well, and performed nearly as good, sometimes a bit better, sometimes a bit worse as our BERT. It was kind of underwhelming for us to train the BERT model and then something zero shots. It nearly the same quality. But then again, X-ray is very simple. So very, very short, and the information is much easier to extract than the way more complex CT reports. Regarding the prompts used, they are available on the GitHub.
I see Amara has her hand raised. Go ahead, Amara.
Yes, so just one small question. When you say you showed the model list of templates, is there a special format that you're using for your template, or it's just template is shown as a free text
We use JSON.
list of sections or something?
We used so the templates, we used existing structured reporting templates and converted them to JSON. So we asked the model to take this JSON format and then fill it out, basically.
Yeah. Thanks for clarification.
So we have one more question from Manlu.
Yes, it's Man. So thank you for the talk. I actually have a question in your second project that when you're generating the question to train the model, so why not you use existing MedQA data sets? Why do you generate your own QA data sets?
We did use some existing data sets. So what I showed there from data was just data we created for this task. We did use existing data sets. We used things from the chat doctor data set, but only a bit because I wasn't that satisfied with the quality. But most of the MedQA data is USMLE questions. So it's usually in a format from the axioms. And this is not really something which I want for the model. Of course, it should see some of the questions to be good at answering multiple choice questions, but I want the model to be more, to explain more. You know, you asked something like, what are symptoms of diabetes? And I want it to be more like one very nice example of questions, actually the patient information from Wikidoc. You have a short question as the heading, and then there's a long explanation. So what are symptoms of diabetes? And we'll go into the details of diabetes. What are symptoms? How you recognize them? And so this is why I created them. And I really like the resource of Wikidoc, to be honest. It's a high quality resource. There was a reason we crawled the data as well.
I see. So for the QA generation, are you using some existing QA generation model, or how do you generate the QA pairs?
I use the OpenAI API.
Okay. And the API will give you the explanation as well?
So you provide, so what I basically did, the Anki flashcards was a good example of this. You have, for the Anki flashcards, you have the question and the answer, but not in the format you want. So you say to GPT 3.5, so I've loved to use GPT-4 for this because it follows instructions better, but this would have been insanely expensive. So I use 3.5. You give the model the question and the answer and ask it to rephrase it to a question and the answer. And it actually does a good job in this, and GPT usually does not add or remove lots of information. Well, not in a case of very short texts. So in long text, it's kind of tends to leave out information, but here it mostly just rephrased this. And then I also asked it to follow a specific template. So say like a special character and then answer in all capitals, or question all capitals. And then I could use regex to re-extract the question and answers quite reliably.
Oh, and may I ask how much you spent on using the GPT 3.5?
Roughly $100.
Okay, so it's
a bit hard to answer because I played around a bit with other stuff there as well, but I think this project roughly costs me $100.
Okay, thank you.
We have another question from Ashish.
So, so I was just looking at the GitHub of your MedAlpaca, right? So I had a couple of questions on that. So one was in terms of like you ran it through some benchmarks, right? But I was just wondering, I'm assuming, I know you're a radiologist. So like, did you get clinicians at your hospital to try MedAlpaca, like in real world clinical decision making? I was just curious. Or
so I would love to do this, but only if I would know that the model is reliable. So at the moment, I would never try to run this in the hospital. I would love to have some clinicians trying it out, but hosting something in the hospital is not that easy. We would have the server for it, but then providing web interface. So I'm able to train the models, but I'm not very good at deploying machine learning models. So this is also a limitation. Certainly would like to try it out with the future model and also check how it would maybe influence, but you have to be very, very careful with that. So probably would take a lot of years to first try it out, like in parallel, to check with doctors, ask doctors what the opinion of the model, then see in parallel if it would do a good job in influencing the theoretical patient pathway. And then if we know that it would be useful, if it would not do harm, we could probably start a clinical trial with it.
okay, and maybe you already talked about it, but I missed the initial part. So I was looking at the GitHub, and so MedAlpaca is like a family of models, right? Where you try different parameter sizes and different quantization and all that. So I was looking at the second last row, MedAlpaca 30B. So it says still training. So is that like the GitHub is not updated, or is that still, like, I was just curious, our intuitive sense is that a larger model with more number of parameters is more expensive to train, but also more performant. So is that kind of the conclusion? And like, did 30B, MedAlpaca 30 billion perform the best among this entire family of models?
Yeah, so the problem with the project is that because of other projects, I had to set it aside and the GitHub is not updated. You can see several branches. For the 30 billion, the issue was that I want to parallelize this to two servers. So we have two DGX nodes, and this was not trivial with the proxy we have in Charité. So I think I now managed with deep speed, but I was just hit with time constraints and could not focus on the project anymore. Would like to revisit this project, but probably will not do a lot of training because I believe the most performance gain is in the data. So if we now will revisit the project and maybe do a version 2 in the future, it will probably be mostly on the data side.
And one final question to so like a lot of doctors talk about this data set called, or resource called UpToDate, right? So I was wondering, like in the context of open source medical AI models, are there something not exactly like UpToDate, but like there's also Medscape. Like there's some people have talked about like scraping Medscape, but like, all kinds of legal thorny issues there. So I was just wondering, are there open source, high quality medical data sets, maybe not necessarily QA data sets, but like, found like more like textbooks or like, something which is foundational to develop like medical reasoning about disease and symptoms?
I'm not aware of it. I think the best shot in the highest quality data are papers. So up to date is behind a paywall, and I think there are lots of writers there, so medical writers curating data, and probably won't be possible to get access to the data because this is a very important IP for the provider, so they will not give it away to a model. I don't think there's anything comparable in open source because it's an immense effort to create those databases. So everything is papers. Open source papers are probably the best information, but you have to filter them for the quality and duplications.
Thank you, and really enjoyed the talk.
Thank you.
Yes,
We
so-
have one more question from Amara. Yeah, go.
Yes. So one small question, I understand like you've done a lot of work in basically curating better, what you expect to be better QA data set. You're saying that question is shorter, the answer is more like an explanation, so it's supposed to be better. Then the question is, do you see any difference in the behavior of your model? Like, does it produce longer explanations in response to a question than any other large language model out there? Do you think, basically, I just want to see like if this much effort has been put into curating this cleaner, more explainable data, does it affect the overall behavior of the model, the output behavior?
We did not run those experiments, to be honest. So we didn't try different versions of we tried some versions of the data, but I never tried the models trained on the old versions because just adding some data iteration of data quality, and we then discarded the old models immediately. I did not check if the output improved a lot between the different models.
Plus, the other question is, even if you decide to run a comparison, if the basically advantage of the model is that it's trained with more explanation, then it's not about probably just answer yes, no questions, right? So, I mean, I'm not sure how to do that, but would be nice to see if the explanation is better, not just a yes, no question, but does it give a more nuanced answer to any diagnosis or any other medical question? Would be interesting to see, but I really don't have a clear picture of how to do that. But
yeah, we need other benchmarks, to be honest, for that. So the benchmarks we currently have, like USMLE, are bad for evaluating medical models because they just check simple knowledge, 1 step, 2 steps in thoughts. And this is not enough for a medical model because you want the model, of course, to get it right, but also to get all the information. So if I asked, again, for symptoms of diabetes, I want to have the model to answer me all possible symptoms and maybe rank them by probability or by relevance. And I think this needs to be reflected in benchmarks, which need to be created. But it's really not trivial. And the thing is also how to evaluate those benchmarks, because they kind of have to be, it's no value if a human has to evaluate the benchmarks like we did with the report texts, because then you're very limited in the amount of models you can train and compare.
Yes, and there's really no straightforward way. I mean, you can think of those machine translation measures like BLUE and Meteor, but again, it will not have that nuance that is needed for answering medical questions. Anyway. I think we have one more question from Ashish.
Yeah, sorry, I seem to be hogging the question, Mike. Anyway, so I had a question on, so maybe slightly extraneous. There's recent work from Microsoft called Lava Med, right? Where they trained it for a very short time in one day. on radiology images. So I maybe slightly extraneous to your talk today, but since you're a radiologist, I thought, so like the problem of you give a radiology image to a model and ask it to explain like what are interesting ROIs, regions of interest in the radiology image. And it can highlight, it can say like, I see a lesion here, I can see a intracranial hemorrhage in a brain MR or something. So I was just wondering, have you looked at it in this work? And if not, like, are you just wanted to hear your thoughts on that?
So not in this work. This work was text only, and of course would be cool to extend it to multimodality, but we did definitely not do this. It was very limited time to do this project. I do most of my other research in imaging, and so the first thing is that usually so the problem is that in medical imaging, what's most interesting for me as a radiologist is 3D data, so CTs, MRIs. And the models usually work with 2D data, so usually X-rays. If they have a CT MRI, they have one slice and not the whole image. And it's very impressive technology, to be honest. So I don't think I could program this. It is very, very advanced and very fascinating. But for a clinical applicability, I'm not that satisfied at the moment with that, because you want to give the whole MRI or CT to the model, which is a lot of data. And at the moment, I'm not aware how you could have the context length of the model to hold all those tokens of picture information, basically, because you have to patch the whole 3D image and then again patch the patches. Yeah.
Like all the slices of a typical MR would be like more than a gigabyte, right? Or maybe more. Right?
Yeah, it highly depends on the explanation. The thing is, you don't have just one. So for MR, for example, let's say MRI of the head, you have several slices and you have several sequences, and you want all of them for the information. So if you want to diagnose a stroke, you want your T2, DWI, and ADC. So there's lots of information. For a CT scan, it's usually 512 by 512, the pixel matrix of the slice, and then there can be up to 1,000 slices.
So do we need a fundamentally new innovation in designing a foundational model for 3D radiology images or DICOM?
If I would know how to do this, to be honest, I would have published this already. So yes, I think we need to find a way somehow to focus on the important parts. Because the problem in radiology is that, let's say 99% of the image is not important for you. Like if there is a cancer on the lung, this is the important part where the cancer is, and not all the healthy lung tissue around it. Obviously, you need to know that it's healthy, but for the diagnosis, this is the important part. So we need to find a way for the model somehow to focus on that important parts and then extract information.
Some notion of attention, right? Some notion of attention, but like tuned for radiology images, right?
Yeah, for this very complex data. So discussing a lot here with my colleagues as well, but yeah, it's really hard to find a solution for this. And usually what they do in these multi-models, they use X-rays, they size them down to 224 or 512. If you would give a radiologist an image on that size, they would refuse to do a diagnosis on that. So usually X-rays are in the 2000 times 2000 pixel resolution, and you need that resolution to be good at diagnosis, see small nodules. I mean, we see in computer vision that models perform very well on smaller resolutions, but still, you would probably prefer for a clinical model to give the full resolution to the model.
Thank you so much.
Great. Do we have any last questions from the audience before we end the session for today? Okay, so then if not, thanks Keno again for the wonderful talk. We'll put up this talk recording on the YouTube channel by tonight. And then if people have more follow-up questions, feel free to reach out to Keno, or if you need us to put you in touch with him, feel free to reach out to us as well. And thanks all for coming today, and then we'll see you next week.
Yeah, thank you so much for having me.
Thank you, everyone.